Important points again I want to mention is for each session we'll have a separate QR code and we'll be displaying the QR code for the each session as well as we'll be sending the links in the particular respective groups and we'll also be sending the link. A prize will be awarded for the best audience question in each session. So let's begin our first session and the topic of the panel discussion is Psychiatry competency-based medical education across undergraduate, postgraduate and subspecialty training, collaborating with MNC, current progress and future directions. I would like to welcome moderator of the session, Dr. Pratima Murthy, onto the stage. I would also like to welcome speakers of the session, Dr. Pratap Sharan, Dr. Sandeep Grover, and Dr. Bhimsen Tekkalki onto the stage. Dr. Pratibha Murthy has finished her MBBS and MD Psychiatry. Okay. Okay. I would like to, I invite ma'am to please take over the session. Thank you.
Yeah. Good morning, everybody. Just wanted to say that this is going to be a very, very important. Yeah. Is this better? Yeah. Just wanted to say it's nice to see that the hall is full. As was mentioned in the morning, that we have a lot of young people in the audience. And of course, that this is going to be a very important session, which is going to look at, particularly at the CBME approach to the training, the competency-based medical education approach. So obviously, we have three very important areas to discuss: postgraduate medical education, undergraduate medical education, and subspecialty training. And we have three very, very well-known teachers, Dr. Pratap Sharan, Dr. Sandeep Grover, and Dr. Bhimsen Tekkalki. I'm very, very apologetic that we didn't have the slides introducing them, because I think for those of you who don't know them, you're really going to understand that they have a huge amount of experience in the field that they represent. Dr. Pratap Sharan as head of the department in AIIMS New Delhi, Dr. Sandeep Grover as professor in PGI Chandigarh, and Dr. Bhimsen as a teacher in KIMS Hubli. But what I'm also going to do is request them, first of all, to give a half-a-minute introduction to yourself. I think that's possibly the best way in terms of what makes you an important part of this panel today. Dr. Sharan, can you go first?
Okay. Thank you, ma'am. I'm Pratap Sharan. I'm professor of psychiatry at AIIMS. I think that is the reason why I'm here, even though my personal reason for coming here is for last 6 years, I have been more of a professor in charge of student wellness, and I've been less of a teacher, more of a grandmother. And these 6 years, I have missed the ITROPS development, so I'm here more as a learner than as a teacher. It's just by chance that I'm sitting on the panel.
Yeah, I am Dr. Sandeep Grover. I am a professor of psychiatry at PGI Chandigarh. Again, Dr. Pratap Sharan has been my teacher, and I also play a similar role with regard to wellness of PG students in PGI. in contrast to AIMS, we are just having a PG curriculum, and that's where my role comes in. And I also take up the role of teaching my students in my department and looking after their training requirements.
Good morning. I am Dr. Bhim Sen. I am Associate Professor of Psychiatry at JN Medical College, Belgaum. Why I am here today is probably because of two reasons. One is I was involved in recent curriculum revision in competency-based medical education for undergraduates 2024 by MNC. And second thing is, as I currently am working in a private institute, probably the organizers wanted somebody from the private institute also to represent, to discuss the various challenges and opportunities in private institute. Thank you.
And do you have an affiliation with Kim Subli?
I am a student, madam.
You're an alumnus of Kim Subli.
Yes, ma'am.
So you bring the experience of learning at Kim Subli to the teaching in Belgaum.
Yes, ma'am.
So excellent. So you have three very, very important people on this panel. And there's only one housekeeping rule that I'm going to make to the panel. It's just to keep your responses brief, so that we can allow the audience also to be partly interactive, and maybe if the audience is going to keep some of their questions to the panelists ready, it will become very useful. But let me dive straight into this particular panel, and especially since the morning's discussion where we had so many teachers, and we really didn't discuss structure to teaching. Now we move on to the structure to teaching. And do you think, Dr. Sharan, that there was really a need for this kind of competency-based medical education, when psychiatric training was going on, since possibly, around independence, more than 5 decades, what do you think is the need for CBME?
And the need for CBME comes from a statement that you made in the morning, that we have been teaching for a long time, but the different colleges have been doing different things, and the standards that are there are very variable. So the CBME basically shifts the model from teaching according to what teachers think is important to what public thinks is important. So it shifts the model to public accountability. You set specific standards, and people are valued as to whether they have learned adequately based on those standards or not. So it moves away from an individual apprentice-based model to an outcome and a public accountability model. So that is the reason why it's important. The other thing is that the whole world is moving towards CBME. So there have been different frameworks, like the Canada's CanMEDS framework, there is the Scottish Doctors framework, the American Academy of Education. The entire world is moving towards CBME, and that's another reason why for international accreditation, it's important that India also took that step.
Thank you very much. So I think you're talking about the need for uniformity in training, particularly when there are so many newer and newer centers coming up all over the country, and the CBME attempts to achieve that. So since its introduction in 2019, Dr. Grover, do you think that the CBME is moving in the right direction in terms of achieving its objectives for psychiatric training in particular?
Yeah, thank you, ma'am. And I think the CBME has come at the right time for, at least for the specialty of psychiatry, I would say that, because it came in 2019, and in 2020 we had COVID, and there was a lot of importance given to mental health. So with this, what we have seen now also, that the time, one thing which CBME has brought is the time given to the psychiatry as a specialty in the undergraduate training has increased, which is going to improve the knowledge of the undergraduate students about psychiatry, and is going to have a long-term impact with regard to the mental health care at the primary care level, secondary care level, and the tertiary care level. And these are also led to major shift in training, as Professor Sharan was saying, from just the didactic lectures to more of competency-based training, where the emphasis is on learning the clinical skills which can be used during the patient care. And in long run, if I look at the CBME curriculum, it will have a lot of long-term impact, and it has already started having impact on the attitude, professionalism, ethics, communication. All these are now becoming much and more important with regard to how we interact with patient and their family members, or among their colleagues. So from that point of view, it is leading to a lot of changes. And also, as we are thinking in the line of patient care, what as the students are given clinical scenarios and they are being trained on the clinical scenarios, this is going to also help in reduction of stigma, at least in the hands of the professional, because we see a lot of stigma in medical professionals also towards psychiatry. So once this training, CBME kind of a training is done, I think a lot of stigma will also be addressed and the patient care is going to be finally be better with time.
For the sake of the audience, can you just quickly enumerate some of these competencies in psychiatry? Yeah.
No, like for competency in psychiatry, like some of the competencies which have been talked about is recognition of depression in the primary care, how to manage depression or how to manage psychosis, how to manage mania or the substance use. These are the or how to address a patient coming with a suicidal behavior. These are certain things which are being talked about in the CBME at this moment, and these are considered to be the minimum basic things which students should be learning besides the communication skills and others.
Dr. Bhimsen, I understand that the curriculum has been modified in 2024. So what are the new things that have appeared in the curriculum?
2024 curriculum has some very important changes. To name few, the most important one is we brought up certifiable skills in psychiatry which were not there earlier. Because as we all know, assessment drives learning. If we don't, students are not assessed, they will not learn. So now that they know that they will have to learn how to diagnose depression because the certification is important. So that helps in for students to focus in psychiatry better. So that's one change. Even the suicide risk assessment is a certifiable skills now. So we have 2 certifiable skills. The overall size, volume of the competency in psychiatry has come down significantly because the idea was to focus only on must-to-know subjects so that a student learns qualitative psychiatry rather than the number of competencies. 6 weeks of clinical posting in psychiatry definitely gives a boost for teachers also to give more time to train undergraduates in psychiatry. So these are some key changes. And also one more important thing is now 25 marks to psychiatry in annual summative assessments where the questions are set by the psychiatrists, not by our medicine colleagues, which used to happen earlier, and key answers are provided. So the validity of this assessment has also probably will also increase.
So you said it's in the summative assessments, but in terms of a question in their
medicine
papers,
paper.
in their medicine paper,
Yes, ma'am.
there is a question.
25 marks
25
for
mark questions
psychiatry.
as part of
Yes.
that. So that is a significant stride that has occurred.
Yes,
So that undergraduates take it seriously. Now this is a question to all of you, and while the panelists are going to answer that question, we will take a couple of questions related to undergraduate training from the audience before we move on to the to the next section on postgraduate training. So the question to all of you is, what do you think are some of the challenges for training of undergraduates, and what do you think are the opportunities? Each of you can reflect on that. Dr. Sharan?
I think I'll take the challenges. Sandeep will probably take the opportunities. Some of the most, to my mind, the most important challenge is that psychiatry forms a very small part of the MCQs that are given for entrance into MD. So it is only 1.5% marks, and that is a major reason why undergraduates don't want to study psychiatry. Even if you have summative assessment with more marks, it doesn't matter in that sense. And the end result of it is that the attendance in most medical colleges for psychiatry is less than 25%. So that is a crucial problem. The other thing is that even though the curriculum in 2019 and 24 have increased the importance of psychiatry, it's still not a major subject. Like in many Western countries, psychiatry is one of the 5 clinical subjects which are considered to be the things which should be taught to undergraduates. Is on par with pediatrics and obs-gynae and medicine and surgery, and more important than other subjects. So here we are giving only about 3% of undergraduate training time to psychiatry. And the 17 competencies that are there in 24 has to compete with about 10,000 competencies in the MCI 2024 for all, like in anatomy there will be probably 600 competencies. Psychiatry has 17. So there is a reason as to why people will focus more on other things. There is low weightage. It's still less than 5% marks in medicine, and the coverage of EdCom, even though we are very upbeat about it, is actually very perfunctory because it covers only about 2 weeks of all the training. So there are obvious limitations, but it's still much better than what was there earlier.
Yeah. Thank you, sir. Sir has alluded to the challenges, but I look this also as a big opportunity. For example, we have been talking about including psychiatry as a separate subject in undergraduate, but we have not been able to succeed. But what we have not succeeded, if we just keep on talking about it, things are not going to change. So what we need to think about, what time we have got in the undergraduate, how does we can make a change with that. And in that, I will put the things into 3 different perspectives. One is the patient care, second is the training, and the third is the research. When we look at the so-called the patient care, as I said earlier also, that if we improve the identification and management skills of the undergraduates with regard to the psychiatric disorders, this will not only have impact on how we treat or how people recognize psychiatric disorders at the primary care level, will also improve identification of mental health issues in people with various physical health disorders, so that it will improve the holistic care in the long term, and also it will improve the referrals to the psychiatrist, because nowadays most of the patients are not referred to the psychiatrist because many times the undergraduates are not aware that this patient possibly has a psychiatric issue, or they leave it to the family without convincing the family that why they should go to a psychiatrist. But if they have skills, I think they will be able to do that in a much better way. So that's where I look at this as one opportunity. The second is the training that sir has talked about, the issues about the challenges. One of the major challenges that we have lack of psychiatric teachers across the country, and there is no homogeneity. So this CBME whole gives us an opportunity that we formulate training for the teachers, and we try to homogenize the skills of the teachers, so that we can impart similar kind of knowledge to the next generation, because this is where a lot of things will change, and the time will tell how it is performing. And similarly, we have to now look at what kind of CBME modules will work in psychiatry, because things which may work in medicine or other specialities may not be applicable to psychiatry, because we cannot have a mannequin to train our students for majority of the things except for 1 or 2. We need role modelings, or we need the so-called the simulation patients and so on. So we will also need to develop these skills and do research in these areas which works for our students and which doesn't work for our students. So this is also a challenge for us, that we start thinking in these lines and start thinking, utilizing this opportunity, so that we actually may turn out to be leaders in guiding other specialties how to train teachers.
Dr. Bhimsen, in addition to talking about advantage and disadvantage, what have been the challenges in taking this to the NMC as well?
I mean, it's not very easy, because NMC comes with its own rules and timeline. For example, when our committee was set up, we were given 1 month time to come up with the new curriculum, and it was not sufficient to go through the whole existing curriculum. And so that's one opportunity, one challenge. Other challenge, we need to know how to navigate with the leadership in the NMC to convince to allot 2 certifiable skills for psychiatry was not easy. So to know how to navigate or how to convince leadership in NMC is also something which we should all think about, and maybe having a good communication between IPS and NMC, and it will certainly help to improve improve psychiatric curriculum changes in future.
You can't possibly be have a better time than now in the NMC. You're probably not likely to get these opportunities very often again. So at this point in time, are there a couple of questions that the audience would like to ask with respect to undergraduate training in psychiatry based on the CBME? I see a hand there. Just introduce yourself briefly and ask your question, and tell us who you want to answer it.
Ma'am, I'm Dr. Raman from Chennai. Ma'am, any of the 3 panelists will be fine.
Okay.
But as far as in CBME for UG goes, so like the glad thing is like they have added certifiable skills and other things they said. But is there an internal assessment weightage that is given? Because as far as UG students are concerned, the final marks addition, they will just again read the few pages of psychiatry or the questions in the psychiatry. So that doesn't boil down to the actual training. So like making them attend the entire clinical posting is still a big challenge with 250 students. And second thing is the certifiable skills, like who is going to certify? Like, it's not an easy thing because like certifiable skill, there is a remedial thing that CBMA is suggesting. So like as far as the other discipline goes, we know how certifiable skills are working. So in our discipline also, that's going to be a still challenge. And the internal assessment weightage is very important because we are struggling with medicine departments to give us like weightage. As far as weightage is concerned and attendance is taken into consideration as part of this, then only the final university marks will make sense, is what my suggestion.
Thank you. Thank you, Dr. Raman. I think your first question is something that the undergraduate sitting in the audience possibly will be able to answer as to why is the attendance so low. The second two questions in terms of the internal assessment and
Can
in
I
terms
take
of the
this one?
weightages. Yeah.
I mean, there is some marginal improvement we have achieved from what it was earlier. Now, I mean, 13 marks out of 100 marks in medicine in phase 3 part 2, 75 goes to medicine, 13 goes to psychiatry, 12 goes to dermatology. So that is some solace that we have right now. Yes, your second question is very genuine, like very valid as to how we are going about with certifiable skills, who will certify. That's the reason we limited certifiable skills to only 2. In our committee, there was a kind of a difference of opinion. A couple of members wanted 4 certifiable skills, but we wanted actually 1. I wanted only 1, but it boiled down to 2. Why? I'll tell you. See, if there are 200 students, let's say if it takes only 5 minutes to assess one student to see whether he can diagnose depression or not, it will add up to 1,000 minutes. So we were a little cautious in adding too many numbers to the existing curriculum. When it comes to who will do it, yes, I mean teachers and also senior residents and postgraduates can also be trained to assess undergraduates to certify them. So this question is there in all subjects. Who will do that? The standard answer is use SRs, use PGs. So that's the...
Yeah. I mean, I think that's again something that has been reflected through the Slido questions from the audience. Who will do it? Do you think the medical colleges will be able to implement the UG curriculum considering the low faculty numbers? And you've partly answered it, but I think that continues to be a challenge. So we have to find other ways of being able to do it. And by the way, I don't think this low attendance among the UGs is specific to psychiatry. I think every discipline is kind of, really struggling with this issue of attendance. And I think that's the same average of 25% attendance. Right. Are there any other hands in the audience? Okay, I'll take... Can I just first ask if there are any students, UGs, who want to ask a question? I'm going to give preference to UGs. Okay, right. While we are waiting, Dr. Jagdisha, and then yourself, yeah.
I'm still a student. So,
lifelong learner.
Yes, ma'am.
Okay, right.
So, my question to maybe the panelists, anyone. So, Dr. Sharon in particular. So, you said that in the Western countries, psychiatry is a major subject. It's given as much importance as any other subject. So what is the challenge? One of the challenges that I know the NMC is facing is that from where do we get the time? Where do we compromise if we give more importance to psychiatry? Which part has to be? So I'm not sure. Is there a solution for this? I think it is a genuine problem.
I don't think it's a simple solution because when you go for interdepartmental or interdisciplinary negotiations, it's not going to be easy. But the logic that Western academic associations give is that psychiatry is a subject which is largely clinical. It is something which can be taught easily to undergraduates. It doesn't require too many instrumentations. So what they suggest is that subjects which are very surgically oriented, where MBBS people can no longer be doing the actual treatments. Like for example, surgical skills in ENT or surgical skills in orthopedics. So mainly they are saying that wherever there is high technology related things, it should be moved up. And psychiatry should be a core subject for undergraduate teaching because it's easier to teach.
Thank you. Dr. Raghavendra?
Good morning. I am Dr. Guru from Bangalore Medical College. Sir, mind comes first. So why not psychiatry has to be implemented in the anatomy or in the physiology itself? You are just bogging into the medicine which is in the end. See, we are facing the threats and suicide which are very common in the first year itself, and still you are getting into the core subject is at the medicine. I think our thoughts, maybe your valuable thoughts.
Yeah, I think you're raising a valid point that rather than starting the psychiatric curriculum in the later half, we should start the psychiatric curriculum as early as possible. But what we need to understand, as we are already discussing here, this struggle between different specialities or the different branches of medicine in the whole MBBS curriculum. That is a major issue which comes in, and that is where we are failing. But if you start psychiatry early, I think it may benefit. Other thing which I just wanted to add, what Dr. Jagdisha had asked, is that we need to understand that in the Western world, people understand this importance of psychiatry, that it cuts across specialities, and the principles of psychiatry work across the specialities. If you focus on psychiatry, you are able to teach the students about communication skills and other things which come handy in all the specialties. That's why possibly there's one more reason that they give importance to psychiatry.
Yeah, I think that's a very attractive point that you're putting forward too, that some of the general principles of training in psychiatry are very useful across specialties, and therefore it might be useful to teach it earlier. Dr. Bhimsen?
Yeah, just the point Dr. Guru pointed out. See, every subject feel that their subject is important, and we felt when we met during curriculum revision that every subject was disappointed that their subject is not gaining, given adequate weightage. In this competition, we forget undergraduate student and his time and his abilities. So we should also keep in our mind that undergraduate students have limited time and resources to learn everything. So what you said is ideal, but let's start somewhere which is practical, and maybe if permits we can move to that point. That's what I feel.
The other thing is that the EdCom modules are started on right from the foundation course itself, and EdCom has various components of communication skills, ethics and other things which are related to mental health to quite some extent. So actually when you teach people early, you are trying to teach them behavioral sciences rather than psychiatry proper. And behavioral sciences, some of it is being covered in EdCom, but more can be done. EdCom is covered by all the departments actually. Even biochemistry and anatomy and other departments are covering EdCom. So they are trying to do it. It's not perfect, but I think it's a move forward.
Okay. Is there any undergraduate who wishes to ask a question? Only chances now privilege to undergraduates. Otherwise, we're moving on. Otherwise, you must rest your questions. Okay. So I will give you another opportunity, out of sheer love for undergraduates at the end of this. So we'll move on to postgraduate training. Now, and I'm going to start off with one of the questions that again has been asked on Slido, which is about UG, but I'm sure it follows to PG itself. And what they're saying is that particularly in private colleges, and I know two of you are from INIs and one of you is from a private college, the ability to have UG and PG, especially in private medical colleges, there appear to be more challenges and resistance. In some ways, what do you do in the INIs, and what might there be lessons for private institutions in terms of applying CBME to PG teaching? Dr. Sharan, let me start off with you. Okay.
Yeah, what is
Dr.
the question?
Bhimsen,
Yeah.
the question is, there was a Slido question saying that this CBME teaching, particularly in undergraduates, there are more challenges and resistance in teachers in private medical colleges. What do you do? How do you overcome that? And you might start off with talking about applying CBME teaching to PGs as well. What has been the progress there?
Yes, I totally agree that the scenario in private colleges is very different and difficult because of less number of faculty and because of less reward they get in terms of monetary benefits and other things, and a huge load of students. So on an average, any private medical college has 200 students, whereas only 2-3 psychiatrists in a department. But nevertheless, it's a mandatory for every department to adopt CBME. So this is where IPS and forums like ITOPS can play a crucial role in sensitizing teachers as to how effectively we can, in even limited time and resources, we can train our students in CBME, how to utilize senior residents and postgraduates in undergraduate training, but it will not happen as long as teachers they themselves come forward and take some keen interests. Otherwise, it's not going to happen. So it's two-way communication that should happen.
And of course, that even the senior residents need to understand the principles of CBME and be in some way feel confident that they can impart it to, which also goes for the faculty. So, Dr. Grover, do the INIs follow the CBME guidelines at the PG level?
Yeah. At present, we do not have exact kind of survey of the data for what INIs are following, but two things which I can just say that which comes from my experience of being the examiner at many INIs, or when I'm going in interacting with my colleagues in various INIs. One thing is very clear that most of the faculty in this institute, most of the new INIs are either from NIMANS, AIMS Delhi or PGI. Now, these three institutes in the country have a very structured training program, and that has a lot of components which were already practiced at the postgraduate level without the CBME being there. So with CBME we are trying to structure for other places, but for these places already had some of these principles already in the place. So from that point of view, there is some amount of homogeneity across different INIs, but when we try to compare it with other medical colleges, I think there is a huge gap where the psychiatry training is being given to the postgraduate in the INIs vis-a-vis the other medical colleges.
Dr. Pratap Sharan?
I think I disagree with Dr. Sandeep, mainly because I think most of the INIs, except for maybe one or two, they have what is called a syllabus. They have a list of topics. Usually CBMEs have not been defined per se. Is there in the minds of people? They are maybe applying it in an implicit way, but at least explicitly, almost no INI has a proper CBME-based curriculum. Actually, most people don't know the difference between, I'm talking even at INI level, that most people don't know the difference between a curriculum and a syllabus in that sense.
So do you think, let me ask you that question then. Do you think what the INIs are doing is the step forward in the right direction because they've been doing it for so many years, or should they be adhering to some of the CBME principles going forward?
Ma'am, I think they have been doing better. At least they have defined syllabus in place. They have specific assessment method. It's kind of halfway there. But ITOPS, I think, should take up this challenge of getting CBME in PG training at a national level. So,
do you think, again, I'm going to turn this question back to any of you who wishes to answer it. Do you think it is better? I'm not so sure whether the PGs, particularly in INIs, only focus on syllabus. I'm sure there is focus on developing skills as well. But how do you think, that there could be some kind of a convergence of these? Can you suggest some specific steps going forward?
Ma'am, this curriculum will have different elements. There will be elements related to knowledge, there will be elements related to skills, there will be elements related to attitudes. And also, if we want to build in other things, that can be built in. Like, for example, the FMC, Chauhan et al., they have come up with what they called EPAs, how to evaluate performance in action in that sense, and they have given a list of 167. Now, all the INIs may not, or all the colleges in India may not agree to those 167, but it can be a kind of a nucleus around which we can think of, like that is one assessment area. So it's not going to be a one-time kind of a thing, but I think ITOPS should start looking into it. At least part of the curriculum should be based on CBMEs, and maybe some, let's say 20% of time can be left for other kind of things, which may be electives or different formats.
Okay. Dr. Grover, there are many PG teachers in the audience, and what do you think needs to be the areas of focus in PG teaching, and particularly from taking up from what Dr. Sharan said, whether it's competency, whether it's building up on this thing of competencies, whether to follow the CBME itself, or whether to focus on other ways of developing competency right through their training, and also developing them not just as safe practitioners, but practitioners with an understanding of how you can apply psychiatric principles in the broader socio-cultural matrix and context.
Yeah, exactly. That is what we need to start understanding, that NMC has done its role of proposing the CBMEs. It is up to the medical institutes and the teachers to implement it. So once we are trying to implement, until as we all reach to a common platform and think about homogenizing the training, what we want or what we want to impart to a student in terms of the clinical skills and the so-called competency which they should have to practice independently, or in that matter that the competency which they gain, they themselves can act as the future generation teachers also, because post-graduation students are also going to be the next teachers. So in that sense, we should not be just focusing on theory, but we should be focusing on the clinical skills, the research, as how they work as teachers. And for that, we at different levels like ITOP, IPS, other professional organizations which are there in this country, and also the different teachers who are in the different medical colleges should agree upon the basic skills which we want to have, that these are the basics, level 1, then level 2, level 3, that first year students should have this level of expertise, at second year this much, and third year this much. And at the same time, the way we also need to, because NMC cannot do things, and we cannot homogenize things happening in all medical colleges because we don't have so much of teachers. So we also need to revise our kind of conferences, workshops which we are conducting across the country as different professional organizations, how we can use those platforms to train PG students so that we homogenize some level of training. We should focus on hands-on training more rather than having didactic lectures or those kind of things, because that is how you can homogenize. You can just, again, we can talk in theory that we need to homogenize, but how do we do that if the students do not have access to teachers, best of the teachers? So if we go by the so-called model that students can come to better institutes for training for 1 or 2 months, that's not going to work out, because there's a lot of red tapeism, bureaucracy, and a lot of things will come in. So professional organizations have to pitch in. We have to form some kind of basic levels, and which all needs to be implemented.
I'm a little concerned about the fact that you used homogenize about 3 or 4 times in your response. Yeah. And while, I think I just wanted to ask you, while we certainly need to have a minimum an acceptable standard, we also look at these institutions to give us novel ways of training, to kind of, more aspirational kind of ways of training. So, I just...
No, when I say homogenize means these are the basic things which should happen at every institute. Above that, anybody can experiment, can come up with new modules and new methods. That's always acceptable, and that is the way forward we need to do it. But what is happening that the medical colleges who just have one teacher, for example, and if he is expected to implement the kind of module which we implement in PGI or maybe in NIMHANS or AIMS, it will be not possible for him to do that.
Okay. So now, Dr. Bhimsen, before I come back to you, I'm just maybe going to ask the audience if there are any questions in terms of the postgraduate training and the CBME application to PG training. We can take 1 or 2 questions before we wind up. Yeah, Dr. Philip Johnson.
Many times there are no clarity on certain like CBME tasks which are given. For example, I'll tell you, in our regular Rajiv Gandhi University curriculum, it is said that students have to do 100 hours of psychotherapy, but practically it doesn't happen. So I think I know we had a lot of discussions on this earlier also. So we should have viable kind of models where students also know that they can take up certain therapies, and it should not be hours or maybe variety of cases they can see, or a particular CBT which is commonly practiced. So I think we need to be a little more specific on that is what I feel, and I would like your opinions on that.
Dr. Bhimsen, we'll start off with you to respond to that. Or
Totally agree, sir. We need to keep in mind the resources we have, maybe the number of teachers, number of the patients. So that's why we need to have a practical approach than an ideal approach.
Because I come from an institute where we already have been practicing this 100 hours of psychotherapy for maybe now close to 60 years. And how it is implemented, I'll just share with you that you are supposed to have 100 hours of psychotherapy, not exceeding 10 hours per patient. So that basically means that you should have carried out psychotherapy for 10 patients. And out of this so-called 10, some of them we will accept as psychoeducation sessions also. So it's not just therapy, because at the end of the day, some of doing proper psychoeducation to the families and patient is also a very important skill. So we need to understand that just talking about psychotherapy and forgetting about the basic aspects. For example, we accept supportive psychotherapy, we accept eclectic psychotherapy. We are not emphasizing that it has to be a CBT or a psychodynamic psychotherapy. But at least when we are trying to emphasize this, it leads to the outcome and students are able to complete it.
I think this is a good example of how a CBME can be utilized in innovative ways in different places. Like, for example, they are using different kind of therapies. Some departments where there will be fewer teachers than in PGI or AIMS also, they may be using something like a balanced group, where they are discussing a normal, their day-to-day patient, but they're doing it in a more reflective manner, and that could also, that is probably the simplest level of how psychotherapy teaching can be brought about. So a balanced group is where you do reflective practice essentially. So you basically learn to think about psychological issues. Apart from that, it's possible, like he said, one could be considering a proper psychoeducation, like if you did sessions on psychoeducation, not the run-of-the-mill kind of a thing, and that is supervised by someone, that becomes a kind of a psychotherapy. In AIMS, most of our faculty members are biologically oriented, so it's very difficult to get them to do psychological kind of work in general. What we have is about once in a week, we have supervisory sessions which are open. So it can be a balanced group kind of a discussion, it can be supervision of psychoeducation, it could be a supervision of therapy. In that sense, in UK, they have a system where for the first 3 years, they have to do 2 cases. One short case which lasts less than 20 sessions, and one long case which lasts more than 20 sessions. So there are different ways in which one can approach this CBME, and CBME is not very restrictive. Usually just gives an ideal, and you have to find ways of how to go about it.
Thank you very much. I think this could have been the discussion for the whole day if we let it go, but I think we have to put a stop to it as we're already behind time. But there's also another question about from psychology. I think the same principles go there, that it should not be just knowledge giving, but also a kind of combination of knowledge and skills and experiential learning. So, but I think the point remains, just to summarize some of the discussions that we've had, it is important to have some structure to our training, to make sure that there is uniformity of training in different parts of the country, particularly where there are fewer number of teachers available. So we have to find some ways of making sure that this training is imparted. While we have the basic training in place, we also need to make sure we make our trainees not just reach these metrics of competence, but really get to much more, to develop a much larger perspective in terms of patient communication, understanding problems in the larger world context, and of course being safe practitioners of the subject. And I think many of the topics going ahead will also be discussing some of these things. I too wish we had some time to discuss the issues in subspecialty training, but I think if you can have it work in the MD program, I think translating it into subspecialty training is not going to be that much of a ordeal, because people would have already been exposed to it in their MD training. So thank you very much to the panelists for providing your insights, and I do hope that as we go, I'm not at all disappointed. I mean, I think it's it's good going forward. It's good that people are looking at psychiatry through the same lens as through other specialties. It's gradually kind of picking up, but I really want to talk about everybody focusing on how we can integrate principles of psychiatric learning and teaching into all aspects of clinical medicine. And doing that, I think, will immediately increase the interest in psychiatry and urge many of you in the audience also to consider psychiatry as an important discipline that you might decide to pursue. Thank you all very much.
I request Dr. Pratibha Murthy to present best question of the session.
So, I'm sorry, this is very arbitrary, and I wish there was a panel to decide on the best question. But I'm going to award the best question to the changes from the 2019 curriculum. It says 29-24. I think it's a typographical error. I wish we could know what happens in 29-24. I presume it's 2024. Was very dramatic and rapid. And how can a teacher imbibe these changes? And I think that's a very huge question, not just between the two curricula, but in general, how can teachers adapt to change? And that's the question that gets the award today. Yeah. The person who asked that question may please come forward. And I might be a Harrod teacher who asked that question.
In AIMS, we have spent 3 years in trying to adapt the 2019 curriculum to our curriculum, and now we have to start all over again.
So, Dr. Harish, you've been thinking very, very hard on this question. I hope you find the answers.
I request Dr. Ashwini T.S. from Center for Health Information to present souvenir to moderator of the session, Dr. Pratibha Murthy. I request Dr. Pratibha Murthy to present souvenirs to speakers of the session. Respected delegates, kindly switch off your mic after once you are done asking the questions.